Hello. In this session, we shall be discussing major spreading orofacial infections. This session is recorded as a PowerPoint show, which means you should be able to flick through each slide and hear the audio recording related to each slide. The aims and objectives of this session are to discuss the sources of orofacial infections, including both odontogenic as well as non-odontogenic sources. We shall try and understand different types of infections, focusing on abscesses and cellulitis and how to determine whether you're dealing with an abscess or a spreading infection. We'll look at the clinical presentation and management principles. So we shall look at sources of infection, starting with odontogenic sources of infection, because you are more likely to encounter patients with odontogenic sources of infection. So the most common one are teeth with infected root canals, whether it's secondary to untreated caries, failed endodontics, or trauma. Infected periapical lesions. So you should be familiar with different types of periapical lesions, including apical periodontitis, periapical abscess, granuloma, or an infected radicular cyst, periodontal infection, dentoalveolar trauma and fractures, surgical wounds in the oral cavity such as tooth extraction wounds, osteomyelitis, which is an infection of the bone, and finally tumors and cysts in the oral cavity which have secondary infection. Less commonly, you would encounter patients who present with non-odontogenic sources of infection, and it's important that you recognize these, including salivary glands. More common ones are mumps, parotitis, and obstruction of salivary gland ducts, leading to sialoadenitis, involvement of paranasal sinuses, leading to inflammation and infection, infections of the throat such as tonsillitis, pharyngitis, epiglottitis, periorbital infections such as stye or cellulitis, skin infections, traumatic maxillofacial wounds and fractures, animal bites, and other systemic infections such as tuberculosis, fungal infections, actinomycosis, insect or human bites. So these images depict some non-odontogenic sources of orofacial infections. You can see a child with severe mumps. Also, you can see stye, which is an infection involving the sebaceous glands in the eyelids, particularly seen in diabetics, cat scratch disease, and tonsillitis. So you should familiarize yourself with non-odontogenic sources of infection. So if you do encounter such patients, you are able to recognize these. The most common type of infection you are likely to encounter in primary care is a periapical abscess, and you would know that an abscess is a localized collection of pus, and with a periapical abscess, the pus usually collects around the root apex of the tooth, hence the name periapical abscess. Now, what you should understand is that the pus in the tissues tends to drain along the path of least resistance. When you apply this principle to abscesses developing in relation to the teeth, you would see that one factor which determines where the pus tends to drain is the thickness of the bone in relation to the root of the tooth. So if you look at maxillary central incisors, for example, the labial cortex is much thinner compared to the palatal cortex, and therefore uh, periapical abscesses related to the maxillary central incisors are more likely to present with a labial swelling, as the labial cortex is much thinner and the pus would tend to drain along this path. And also remember that periapical abscesses are generally mixed infections predominated by anaerobes such as fusobacteria, porphyromonas, and beta hemolytic streptococci. So you must have an understanding why some teeth, abscesses related to some teeth present with a labial swelling and why they present with a palatal swelling with other teeth. And it's primarily related to the position of their roots and the thickness of the overlying bone. Now, if you look at the maxillary lateral incisors, the root of the maxillary lateral incisors has a palatal orientation, and therefore the palatal bone is thinner, and that is the reason why abscesses related to maxillary lateral incisors present with a palatal swelling. And in fact, if you see a palatal swelling in the upper anterior region, you can put your money on the upper laterals because uh, abscesses related to upper laterals usually present with a palatal swelling. You can apply the same principle on maxillary molars, for example. So obviously infections related to the buccal roots of the maxillary molars are more likely to drain on the buccal aspect of the tooth because the buccal bone is thinner, whereas infection related to the palatal root is more likely to drain on the palatal side. But the second factor which is going to determine where the abscess tends to drain is the position of the adjacent muscle attachments. So you would know in the region of the maxillary molars, you've got attachment of the buccinator muscle on the buccal aspect of the tooth of all the molars. And if the root apices of the maxillary molars are coronal to the attachment of the buccinator muscle, the abscess would tend to drain in the buccal vestibule. So you can see an intraoral swelling in the buccal vestibule. On the other hand, if the root apices of the maxillary molar are apical to the attachment of the buccinator muscle, pus is going to drain into the buccal space, not intraorally, but you would see a swelling in the cheek. So these two factors are important when ascertaining the presentation of uh, periapical abscesses. One is the position of the root and the thickness of the overlying bone, and the second factor is the uh, relationship of the root apex of the infected tooth to adjacent muscle attachments. In addition to periapical abscess, patients can also present with a periodontal abscess, and the key differentiating diagnostic feature of a periodontal abscess is that with the periodontal abscess, the offending tooth would be vital, whereas with periapical abscesses, the offending tooth would be non-vital. So vitality is an important diagnostic test which you should undertake when evaluating abscesses. And obviously, if a tooth has an endoperial lesion, then you could still have a non-vital tooth with a periodontal abscess. One of the most important things you need to understand are the differences between an abscess and cellulitis, because an abscess is a localized collection of pus and periapical abscesses or periodontal abscesses can usually be managed safely in primary care settings. However, if a patient presents with a spreading infection or cellulitis, then it might be best to refer them to secondary care. So what are the features of cellulitis or a spreading infection? Cellulitis presents with diffuse inflammation which involves a large area and is poorly demarcated. Whilst you can have large abscesses, but still you should be able to feel the extent of the abscess and you should be able to localize it to a particular area. With cellulitis, the swelling is diffuse and poorly demarcated, so you can't really tell the definitive boundaries of the swelling. And secondly, uh, abscesses are generally fluctuant and soft in consistency, at least in some areas where the pus is attempting to drain. Whereas with cellulitis, the swelling is indurated, it's board-like, it has a woody feeling. And if you compare the pain associated with uh, an abscess and cellulitis, whilst even patients with uh, toothache due to pulpitis or a periapical abscess or apical periodontitis, they might tell you they've been through the roof with the pain. The pain associated with cellulitis is much more severe, and to be honest, you'll be able to tell from the expressions of the patient and the condition of the patient how much pain they are in. They wouldn't need to explain. So the pain associated with cellulitis is manifold compared to an abscess. And then patients with cellulitis may present with marked systemic features. So high fever, severe malaise, uh, whilst lymphadenopathy uh, is also common, but because of the diffuse nature of the swelling and the board-like consistency, you may not be able to palpate the lymph nodes. It's interesting how many clinicians record lymphadenopathy with when assessing patients with cellulitis. Generally, it's very difficult to palpate the local lymph nodes unless you can identify lymph nodes beyond the extent of the swelling. And in addition to that, patients with cellulitis might have a drop in their blood pressure, they may be dehydrated, their urine output might be reduced. So these are some of the features you must note. And also, the most important thing is that cellulitis can be potentially fatal because of the spreading nature of the infection. It can involve the upper airway. That's the most uh, uh, important reason when it comes to risk of fatality. So involvement of the upper airway by the infection can compromise the breathing and can be potentially fatal. Likewise, difficulty in swallowing can also be a sign of spreading infection. And moreover, patients with cellulitis are also at risk of developing sepsis or endotoxic shock. So these are the things you need to evaluate when uh, assessing patients with cellulitis. So the bottom line is that an abscess is a localized swelling with minimal systemic features and can be managed safely in general practice settings in primary care for most patients. Whereas cellulitis is a diffuse spreading infection with marked systemic features and warrants prompt referral to secondary care because these patients need to be managed in a hospital setting as inpatients rather than being treated as outpatients in primary care settings. This image depicts how infection from teeth can involve fascial spaces. So fascial spaces are potential spaces in the uh, layers of the deep cervical fascia and can be involved with spreading infections. So for example, from the lower molars, if the root apices of the lower molars are coronal to the attachment of the buccinator muscle, the infection may involve the vestibular space. Likewise with upper molars. So number one is the vestibular space. But if the root apices of the molars are apical to the attachment of the buccinator muscle, infection can involve the buccal space, which is number two. In other words, it can involve the cheek tissue. Similarly, if the root apices of the lower molars are coronal to the attachment of the mylohyoid muscle on the lingual aspect, the sublingual space may be involved. As you can see, uh, it's marked as number 4. Whilst if the root apices of the molars are apical to the attachment of the mylohyoid muscle, the submandibular space may be involved, which is marked as number 5. And similarly with the upper molars, the palatal space may be involved, which is number 3, or the infection can be transmitted to the maxillary antrum. So this image just highlights some of the spaces into which odontogenic infections may spread. This is another image which depicts spread of infection from odontogenic sources. Number one is the parapharyngeal space and the tonsillar area. Number two is the space between the medial pterygoid muscle and the ramus of the mandible. The medial aspect of the ramus of the mandible, that's the pterygomandibular space where you frequently administer your ID nerve blocks. Then number three is the submasseteric space, which is the space between the lateral aspect of the mandibular ramus and the masseter muscle. This is particularly painful. And number four is the buccal space. If the infection spreads beyond the attachments of the buccinator muscle. However, if the infection is limited by the attachment of the buccinator muscle, as discussed previously, the vestibular space would be involved. This image depicts some of the other spaces which may be involved. So this is the position of the mandible, the medial pterygoid muscle, the masseter muscle, the temporalis muscle, and the lateral pterygoid muscle. So infections involving the space between the medial aspect of the ramus and the medial pterygoid muscle will involve the pterygomandibular space, whilst on the lateral aspect of the mandibular ramus, the submasseteric space may be involved. Infections may also involve the superficial temporal space or the deep temporal space, which is between the temporalis muscle and the lateral aspect of the skull. So just familiarize yourself with the location of different fascial spaces in the maxillofacial region in order for you to understand how they might present clinically. This is a clinical image of a patient who has a right buccal space infection. So as discussed previously, if the root apices of the molars in the maxilla or the mandible are apical to the attachment of the buccinator muscle, infection may spread into the cheek tissue, giving rise to what we call a buccal space infection. And finally, we can look at uh, involvement of the sublingual and submandibular spaces. So you would know that the mylohyoid muscle is attached on the mylohyoid ridge on the medial aspect of the mandibular body. So this is the mylohyoid muscle on either side that's attached to the mylohyoid ridge and forms the floor of the mouth. The space above the mylohyoid muscle is the sublingual space, which also houses the sublingual salivary gland, whereas the space below the mylohyoid muscle, inferior to the mylohyoid muscle, is the submandibular space, and it also houses the submandibular salivary gland. So if the root apices of the mandibular molars are coronal to the mylohyoid muscle, the sublingual space may be involved with the infection, whereas if the root apices are apical to the attachment of the mylohyoid muscle, the submandibular space might be involved with infection spreading from the mandibular molars. So this image summarizes all the key spaces in the maxillofacial region which may be involved with spreading fascial infections. So this is the mandible. So starting anteriorly, you've got the submental space. Laterally, you've got the submandibular space, the sublingual space, and then you have the lateral pharyngeal space, the pterygomandibular space, the submasseteric space, and then the yellow is the retropharyngeal space, and between the retropharyngeal space and the prevertebral space, there is an area known as the danger area or danger space where the neck communicates directly with the posterior mediastinum and diaphragm, and infections from retropharyngeal spaces can spread directly into the mediastinum, leading to involvement of the thorax and lungs with any spreading infections. And as you can imagine, there is a high risk that these infections may have a worse outcome and may be potentially fatal. This is a clinical image of a patient with a sublingual space infection. Obviously, if the sublingual space is involved, it is going to raise the floor of the mouth and push the tongue to the opposite side. So that's the classical presentation of a sublingual space infection. Infections involving the mandibular molars, where the root apices of the molars are apical to the attachment of the mylohyoid muscle, are more likely to involve the submandibular space, which will manifest clinically as swelling in the submandibular region beneath the inferior border of the mandible. So you would be more likely to encounter extraoral swelling with a submandibular space infection. The third space associated with the mandible is the submental space, which is located between the two bellies of anterior bellies of the digastric muscle, and isolated involvement of the submental space can be seen with infections related to the lower anterior teeth, lower incisors, and is likely to produce extraoral swelling beneath the chin. One of the most recognized form of cellulitis in the maxillofacial region is Ludwig's angina, which involves submandibular spaces bilaterally and secondarily may involve the sublingual and submental spaces as well. So the key features you are likely to encounter in patients with Ludwig's angina are involvement of the submandibular spaces with extraoral swelling along the lower border of the mandible. Obviously, in this patient, the right submandibular space seems to be involved more compared to the left, but if left untreated, it would not be unusual for the infection to spread bilaterally. And you would also expect in this patient that the mouth opening would be reduced significantly, the floor of the mouth would be raised, and there would be insufficient room to accommodate the tongue as the infection spreads further. And also, you would expect some systemic features such as fever, malaise, and lymphadenopathy. So this is another patient with Ludwig's angina, and you can clearly see bilateral swelling related to the submandibular spaces, and the tongue is popping out because the sublingual spaces are also involved, and there is which has raised the floor of the mouth, leaving insufficient room to accommodate the tongue. And this is a very important point for you to note. The patient has a tracheostomy tube in situ because the infection has caused compression of the upper airway, leading to breathing difficulties. And therefore, we'll discuss more in the management. If you have a patient with an abscess, you can treat the abscess using a number of possible options, such as access opening and pulp extirpation. You can treat it by tooth extraction. You can also treat it by uh, an incision in the buccal vestibule if it's presenting with a vestibular abscess. Under no circumstances you should use antibiotics to treat abscesses. Whenever there is an abscess, the rule is incision and drainage. And when you apply that principle to teeth, drainage can be accomplished either by access opening, tooth extraction, or a vestibular incision as appropriate. But when you're dealing with patients with cellulitis, it is best to refer them urgently to secondary care where they can be managed as inpatients, where they can be provided with uh, intravenous antibiotics, they can be provided IV fluids, because you can imagine such a patient would have uh, uh, difficulty in swallowing and their oral intake would be compromised, so they may need parenteral nutrition. And very importantly, if their upper airway becomes involved with infection at any point, uh, they can be managed with assisted airway using a tracheostomy. So surely, if you send these patients back with antibiotics, that can be potentially fatal. So that's the fundamental difference between management of an abscess and cellulitis. Abscesses you can manage uh, in most cases in primary care settings, whereas patients with cellulitis whose airway is at risk need management in an inpatient settings in a hospital. This is yet another example of a patient with Ludwig's angina. Classical features of submandibular swelling. There's a tracheostomy tube in situ. The tongue is popping out due to elevation of the floor of the mouth. And you can also see three surgical drains which have been inserted using submandibular incisions. Now, patients with cellulitis, they have a they present with diffuse swellings involving large areas which are poorly demarcated. You don't expect these patients to have a lot of pus in the tissues. It's usually an inflammatory exudate, and the purpose of these drains is not to drain pus, but to decompress the tissues. And again, such treatments cannot be undertaken in primary care settings, and these patients therefore need to be referred to a hospital where they can be managed as inpatients. This clinical image depicts presentation of a lateral pharyngeal space infection. As you can see, swelling in the uh, lateral wall of the pharynx, which has pushed the uvula to one side. So this is the classical presentation of lateral pharyngeal space infection. So when assessing patients with spreading facial infections, it is important that you examine the position of the uvula, if it's central or not. If it is deviating to one side, that might be indicative of involvement of the tonsillar region and the possibly the lateral pharyngeal space. Apart from Ludwig's angina, another form of cellulitis, which is commonly seen in the head and neck region, is periorbital cellulitis. So periorbital cellulitis may result from infections spreading from the maxillary canines and the premolars, and can lead to swelling of the periorbital tissues and partial closure of the palpebral fissure. And then infection may secondarily involve the eyeball and may spread further through emissary veins connecting the uh, eyeball with the cavernous sinus, and lead to infection of the meninges and the brain. And you can see on this axial CT scan that on the involved side, the maxillary sinus outline appears to be hazy, whereas with on the normal side, the classical air-filled maxillary antrum can be seen. So whenever you see patients with periorbital swellings, it is best to refer them and not try and manage them in primary care settings. So this case shows an example of severe periorbital cellulitis, which has led to complete closure of the eye on the involved side, marked facial swelling, and the infection has involved the eyeball itself with suppuration involving the eyeball. So therefore, whenever you see patients with periorbital cellulitis, it is best to refer them promptly to the secondary care so they can be managed as inpatients and any complications can be prevented. Patients with spreading orofacial infections are at risk of sepsis, which is a potentially fatal condition, and you must familiarize yourself with red and amber flags uh, for evaluating the risk of sepsis. I'm not going to read out all of this, but generally speaking, deterioration in conscious level of the patient, which you can easily determine using AVPU scale, a drop in blood pressure, increased heart rate or respiratory rate, uh, indicate a spreading infection and a high risk of developing sepsis. Uh, Also, if you have pulse oximetry available in your practice, you can determine their uh, oxygen saturation levels, and anything below 92% indicates uh, a compromised uh, respiratory status. Similarly, non-blanching rashes or mottled ashen gray appearance or cyanosis indicate a more severe infection. And if they haven't passed urine in the last 18 hours, that is also very significant. Obviously, you can't measure the lactate levels, but basically what it indicates is metabolic acidosis, which is also a feature of sepsis. And any recent history of chemotherapy that is within the last 6 weeks is also significant. So I would urge you to familiarize yourself with red and amber flags of sepsis, which will help you make decisions regarding the need for referral to secondary care. Finally, we can review the principles of management of a patient with spreading infection. You must undertake a comprehensive clinical assessment, which should include a detailed medical history, in particular focusing on conditions which may compromise host defenses. So conditions such as uncontrolled diabetes, history of steroid therapy, immunosuppressive therapy, chemotherapy, any history of malignancy, any history of advanced hepatic or renal disease, alcoholism, etc. And then obviously you would also take a dental history, and then you should assess their consciousness level. Do they appear well oriented in time and space? Are they responsive? Or do they appear drowsy or disoriented, which may be a sign of a serious or spreading infection? Then you should also assess their vital signs, that is, their heart rate, blood pressure, respiratory rate, and temperature. I know dental professionals are not used to assessing vital signs in primary care, but you should have all the equipment available to carry out these assessments, and you should have the skills based on your medical emergencies training. And it's absolutely important that you carry out the assessment of vital signs, because that's going to markedly improve your management plan for patients with spreading infection. Also ask about the frequency of urine output, because uh, delayed uh, passage of urine or any interruption in passage of urine might be indicative of uh, a deteriorating status of the patient. And then also you should carry out local examination, uh, evaluating the size and extent of the swelling, the consistency of the soft tissues. Do they appear soft or firm or more woody or board-like, which may be indicative of cellulitis? And are there signs of uh, respiratory involvement? Are they having any difficulty in breathing or swallowing? So these elements you must assess appropriately, and based on your clinical and assessment, including any investigations you may undertake, you should be able to determine the source of infection. And based on these findings, you can determine the need for referral. Uh, some conditions which may warrant uh, referral to secondary care include difficulty in breathing or swallowing, moderate to severe trismus, that is maximal interincisal opening less than 2 centimeters, swelling extending beyond the alveolar process, elevated temperature greater than 101 degree Fahrenheit, severe malaise or toxic appearance, particularly a deteriorating consciousness level, compromised host defenses, and if, in your opinion, the proposed management might include treatment under a general anesthetic, then obviously you can't undertake that in primary care. And finally, a history of failed prior treatment might also constitute one of the elements uh, which warrant a referral. You must recognize your limitations in primary care, and if you encounter patients with spreading infections, then you must refer them to secondary care promptly. And what you're going to do is you're going to call the switchboard of the local hospital and ask to speak to the on-call MaxFax and explain to them why you are referring. If you're going to turn around and say, I'm referring because I've got a patient with toothache and gum swelling, they are not going to accept the referral. So make sure you justify your referral, uh, considering the criteria for referral. So that's absolutely important. And then you must also ensure appropriate transport of the patient to the hospital and document the case history in your clinical notes. So in summary, the management of patients with spreading infections focuses on a comprehensive assessment based on history, clinical examination, and appropriate investigations which may be undertaken in primary care settings. You must identify the source of infection. Uh, if you can, obviously, if you are unsure, then that might also constitute a reason for referral. Determine the severity of infection, identify the risks, particularly risk to the upper airway or with periorbital infections, risk of spread of infection to the meninges or the brain. And then based on these findings, you would plan your management, including referral to secondary care.